Good evening, friends, and welcome back to the Thursday evening teaching sessions brought to you from Lokmanya Tilak Municipal Medical College and Hospital, Sion, Mumbai. We once again thank the authorities at Sion Hospital for allowing us to conduct these classes here, and the Alchem Division Alpha Max for giving a scientific grant to facilitate the live relay of these classes. Once again, our format is one case followed by a small topic discussion. So today's case is being presented by Dr. Payal. Dr. Payal.
Good evening, everyone. My case is a 9-year-old girl, first by birth order, born of third-degree consanguineous marriage, Vadari by community, Hindu by religion, resident of Parbhani, brought and informed by mother, being reliable, with complaining of difficulty in walking since last 4 years, protrusion over chest since last 4 years, not gaining adequate weight since last 4 years, and difficulty in holding heavy object in hand noticed since last 2 years. Mother has noticed that while walking, child is taking heel off the floor and preferring to walk on toes, which gradually increase over last 4 years, more on the right side than left side. Also, history of falling on ground in between walk is present. Mother has also complained of child has gradually developed difficulty in sitting to stand, which is more than standing to sit, such that child usually requires support of other family members or takes support of floor while standing. She also uses both hand on knees while standing. Also, child has weakness in both upper limb in the form of difficulty in holding heavy object or dropping small household container on floor noticed over last 4 years. However, she is able to feed herself and able to carry small object in hand. In daily routine activities, she requires support of family members while squatting or standing. Child has bony prominence over chest in upper middle part, initially noticed at 4 years of age as small protrusion, which gradually increase in both size and shape. It is not associated with difficulty in breathing, no history of similar swelling on other sides of body. Child has also complained of not gaining adequate weight and decrease in oral intake noticed over last 4 years. However, whenever child is, according to mother, whenever child is gaining weight, some haltering occurs such as loose motion start last for 5 to 6 days, and again back child loses all weight that he has gained. There is no history of altered sensorium or convulsion or unilateral movement. There is no history of radiating pain, no history of any diurnal variation or intermittent symptom with fasting or exercise. There is no history of muscle cramp or muscle There is no history of muscle cramp or muscle pain or muscle twitching, no history of any deformity over spine or base of skull, no history of any sensory loss or bladder bowel incontinence. There is no history of fever spikes, no history of any chronic drug intake, no history of this weakness since birth or at the time of birth, no history of any asphyxia, or in the neonatal period, no history of any respiratory distress. Child has no history of constipation, mental retardation, protruding tongue, or macroglossia. There is no history of recurrent lower respiratory tract infection. According to developmental wise, actually child has some gross motor developmental delay I have noticed, so I am putting it first and in detail. Gross motor wise, child has neck holding at 5 months of age, sit with support at 9 months of age, sit without support at 15 months of age, stand with support at 18 months of age, stand without support, and simultaneous started to put small steps independently at 2 years of age, able to walk with infrequent fall in between at 2.5 years of age, was able to run at 3 years of age. Till 4-year child was appear like that all right, but at 4 year of age, mother has noticed that child is repeatedly falling while playing, or whenever she is running, she used to fall in between. Fine motor wise, all milestone are achieved normally. Language wise, child has had bisyllable at 12 months of age and now tells stories. Social wise, she used to play with friends till 4 years of age. Now she goes to school in third standard and average in scholastic performance. Uh, Past history wise, no history of previous hospitalization. Antenatal history wise, spontaneous conception registered, received supplementation, taken to TT injection, 3 USG scans done, told to be normal. No history of fever with rash on any drug intake or increase in BP. Birth weight, child is term baby, normal vaginal delivery, birth weight of 2.5 kg, baby cried immediately after birth. No history of any NICU stay or any child has received birth vaccine. Immunization wise, child has immunized till 2 years of age according to National Immunization Schedule. Um, Dietary history wise, child takes mixed diet from family pot. Calorie wise, she has intake of 700 kilocalorie per day versus her requirement is 1300 kilocalorie per day. She is deficient in 600 kilocalorie and 8 gram of proteins. Family history wise, no born of third degree consanguineous marriage, no family history of similar complaints. Child, his first born 9-year-old girl and last child of 1.5-year-old. She is not able to stand without support. Otherwise, all other babies are normal developmentally. Socioeconomic history wise, family belongs to lower middle class of modified Kupusomi scale. My summary is 9-year-old girl.
So how will you analyze this? Difficulty in walking since last 4 years. That's the chief complaint. What are your thoughts? What are your thoughts? Means you're going to get this complaint again in another child. So how are you going to take your history? That will depend on your thoughts, no? So you have to start from a wide base and then narrow down gradually. So what could be the various reasons for this difficulty in walking? Or you want to ask something even before that?
Was the child walking normally before, like, was the child walking before the onset of these symptoms? Is it some new onset or has it always been like that?
Very good. So one, you want to check whether the child was absolutely normal before this and whether these are new onset symptoms. What else? So means, see, what we are trying to tell you is we are trying to make you think. Okay. So suppose I tell you I have difficulty in walking. What do you make out of it? Do you make out that my knee is paining, so I have difficulty in walking? Or do you make out that I have developed a hemiplegia, so I have difficulty in walking? What do you make out when I say I have difficulty in walking?
It depend on history, acute history or chronic. If it is like in last 6 hours or 12 hours, then maybe acute onset of paresis. Or if it any trauma or acute history, then we can take any toxin induced like botulism, etc.
So all that is cause. All that is cause. What again? What did I say? Come from a broad to a narrow situation. Is it possible that I have nothing wrong with my legs, but I have difficulty in walking? What could be wrong?
The causes can be anywhere from brain till muscle. So we can differentiate based on elaborating the history.
Correct. So tell me, no, I asked you a pointed question. There's nothing wrong with my legs. Why should I have difficulty in walking? Tell me possible reasons. Then we'll start, we get an idea, okay, what are the all possibilities. But I have nothing wrong with my legs. So muscle tone power is normal.
When child feels most difficult part, it's during the initiation of walking or after some steps he's feeling difficulty.
Suppose I can't see. Will I walk normally or I'll have difficulty in walking?
Difficulty.
So what we are trying to say is think wider, think from all. So this is how you'll have to take history. So first question would be absolutely all right. Second question would be what exactly is the difficulty? Can he walk, not walk? Does he need support? Does he, whatever, all details.
So I think whenever there is a problem like this, first, painful or painless? That's your first question. Now, let's believe this is painless. If it is painless, then motor system. So ask history about power, tone, incoordination, abnormal movement, nutrition. How do you ask that? On lying down, can you move your legs? So yes, I can. So there is no paresis. Is there any abnormal posture? Then you know the tone. Of course, mild tone change will not be noticed. But yes, these are the questions you need to ask. Okay, when you sit down or when you are made to stand, do you keep stable or you have instability? So I'm looking at that. Is your eyes fixed at one point or they are moving? So I'm looking at the cerebellum in coordination. Do you have any abnormal movements, any movements like this, tremors, whatever? Each part of the motor system will cause you difficulty in walking. It's easy to make out. What about sensory system? Okay, not easy to make out, but for example, if I have a sensory problem in my legs, when I'm asked correctly the question, I say, when I go down, I don't kind of estimate the depth. I suddenly feel I've gone down. So can I hold my chappals or they slip? Get you an idea that there could be a sensory involvement. Then ask further, do you have a tingling numbness? So motor system abnormality, sensory system abnormality. We have already talked about ataxia as incoordination, which could be even sensory ataxia, cerebellar ataxia, or even the ear. So ask whether you have a vertigo. That also is going to cause you difficulty in walking. So see how far you can go by just first sentence, difficulty in walking. And this is the thought process. Now you narrow down. Do I have a vision problem? Okay. Do I have an ear problem? Do I have a motor system, sensory system, cerebellum, etc., etc.? Okay. Now, unless you know this, and all your negative history must come from that. You must say that no history of visual disturbances, no history of feeling giddiness. Now, these are negative histories. And how do you pick up a negative history? When you think broadly what all can be the possibility, then I ask positive or negative history. And that's the way anatomy is first picked up. Otherwise, we will not know the anatomy. Anything is possible. Okay. So, give us an idea what could be the anatomy here within limits. It doesn't matter if you have not asked all these questions. After all of us are learning. I've said it again and again, we are also learning when we teach. Okay. So, whatever you know out of what I asked, or your imagination now, you say that no visual problem, no vertigo, whatever, right?
So you've given some history about the thing, na? That there is toe walking, right? You said, and
toe walking. Now, what does toe walking mean? Yeah, sit down. Doesn't matter. We know that.
bus.
Because there are some other symptoms in the first slide, but we'll take it as that. What do you mean by toe walking? Where is the problem again? Where is the anatomy of abnormal walking like toe walking? So why should I walk like this?
Very basic, simple thought process. Why should somebody walk on toes? Calf muscle
Muscle tone is increased.
is increased. So that is one possibility. Any other?
Pain in the heel.
Hmm?
Heel pain.
Okay, pain in the heels. Okay. Now I'm asking you a question. Suppose there is a peripheral neuropathy and the person has a foot drop. Will they walk on their toes? He has a foot drop, so his foot has dropped like this.
They will drag the foot and walk.
So they won't be able to bear weight on the toes, right? Very good. So calf muscle hypertonia or pain in the heels, right? Now now extend this. So why should there be calf muscle hypertonia? What could be the reasons why you get calf muscle hypertonia?
Upper motor neuron lesion.
Where? Upper motor means brain or
Spine.
spinal cord or both?
Both can.
Okay, so explain both. Which kind of a brain lesion will give rise to? Now, is one more question, is it very crucial here? This toe walking and calf muscle, is it unilateral or bilateral in this child? Bilateral always. Why? Because if it is unilateral, will it be toe walking? What will be that?
Circumduction gait.
Or limping. So therefore, this is, if the history is toe walking, that means it's bilateral. So now tell me which central lesion will cause bilateral toe walking? Or toe walking? Or calf muscle hypertonia or spasticity?
Pyramidal tract lesion. Pyramidal tract.
Yes, but which kind of a pyramidal tract? See, the moment you say bilateral, it becomes a little narrow and difficult to fit into a central thing. Because central is mostly unilateral, no? In the brain, you can't have the same thing, mirror image affection of both sides, no? Right? So which central lesion can cause spasticity in the lower limbs? Come
So the
on.
point is that the lesion has to be in the center on both sides. So both sides pyramidal tract are getting involved. Obviously not in the cerebral cortex, they are all far away. But where do they come closer? Well, not together, but closer. Up there they are so wide. Then thereafter they come closer. So where do they come closer? Pyramidal tracts.
Decussation.
Huh?
At the level of decussation, crossing.
Level of decussation, so that's medulla, pons, all that area, right?
Okay, now they're still apart. They're not together. What is in between them? Can there be a problem because of which something in between is causing external pressure on both sides?
Syringomyelia. So basically what you're trying to say is dilatation of the...
Okay, so put dilatation up there, call it hydrocephalus. Syringomyelia is same as hydrocephalus. So hydrocephalus will affect bilateral pyramidal tracts as you come down there. Okay, now that is how you start thinking about it. And if it's a hydrocephalus, then you will ask whether it is headache, vomiting. So again, a negative question of headache, vomiting in a child who cannot walk. Okay, and he will come only with a change in tone, not change in power. And the first symptom would be a change in tone. It's not easy to pick up on history, but bilateral, so it has to be somewhere lower down. And if it's bilateral, lower down, if it is right in the brain tissue only, like it's in the midbrain, medulla pons, whatever, there are a lot of other structures like cranial nerves. Okay, down there, cerebellum is very close by. So if it's an isolated problem of walking, then it's not right in the substance of midbrain. Okay, it has to be a hydrocephalus causing that. Otherwise, you would have many other symptoms and signs. So this is how you kind of talk about. So this child possibly doesn't have a central cause, right?
Now you said spinal cord. So now someone talk of spinal cord as a symptom of upper motor neuron spasticity and toe walking. So just think generally, what are the most prominent features of any spinal lesion clinically? Something which always stands out. Radiating pain, yes, but provided it is a nerve root problem.
Level of
Okay. So one is a level. Anything else?
Sensory involvement and bowel bladder involvement.
Yeah. So,
The question is again, it's bilateral problem. So which spinal problem will give you bilateral spasticity? That's what we are discussing. So what kind of spinal problem? So it has to cut through. See, spinal cord is a small area, and the blood vessels supplying spinal cord are really circumferential. So any part of the blood vessels, spinal vessels affected will affect the entire spinal cord at that level. At that level, you may have different signs. Then below that level, you will have an upper motor neuron signs. So whether you have any such spinal lesion which is going across the spinal cord, and below the level, you will get the. So that would be one way to go by. Okay.
and also when you said calf muscle hypertonia, so to cause toe walking, what else has to be there besides the calf muscle hypertonia? So you have calf muscle are your posterior muscles. What should the anterior muscles have?
In the toe walking, like a child is using his toes and not heel, so there may be the weakness of muscles that are required for the flat foot. For regular walking, like dorsiflexors of the leg, dorsiflexors of the sole, if these are weak, then child will usually prefer to walk on toes.
Yeah. So what you're right. So what I'm trying to say is that there has to be an imbalance in the power of muscles. Then only you can have toe walk.
So imbalance could be one group atrophied, the other normal, or the one abnormal and the other one normal. So
This will not happen in a spinal cord lesion, right? So spinal cord lesion often has asymmetry, which is asymmetry of left side versus right side, but not anterior and posterior asymmetry, correct? So that point takes you away from the spinal cord. So now you think back, do any of your GPS, any of your transverse myelitis, do they have toe walking? None of them have toe walking, right?
So now we have gone out of spinal cords, gone out of higher intracranial compartment. Come down now. We believe here that this is painless, vision is all right, no vertigo, etc. So we are dealing with something to do with motor system or a sensory system. Now we have come up almost to the periphery now. So now tell us, could it be the root? Could it be the nerve? Could it be neuromuscular junction? Or could it be the muscle? So rule out one by one and define the anatomy first.
Now, root would have caused some pain.
Very good. The root causes pain. So already we have no history of pain. So what has he said? Pain could be inflammatory or neurogenic. When we asked for pain, we also had in mind neurogenic pain. So no pain, fine.
Nerve itself would have caused some paresthesia or sensory symptom tingling. There is no.
So tingling numbness. Okay, that's what you can ask a thing. And we did discuss what can a sensory system do while difficult in walking. What about neuromuscular junction?
A diurnal variation would have been prominent.
And often localized, not generalized, etc. So you have a muscle. Okay. So anatomy is muscle. How we have derived just by that. Now just go back one slide and you have some more symptoms there. We just discussed the first part of the symptom. What is this protrusion of chest? Now, in the light of what we have discussed, we are going to answer probabilities on those two things, right? How can a person who has some muscle disorder has protrusion of chest?
Any thoughts?
So again, the same way, you want to know whether it's a localized defect or generalized bony defects. So you want to know whether, have you seen any other limb defects, any epiphyseal defects? Okay, which means I know that this is the local problem. Otherwise, it could be any kind of rickets or chondrodystrophies, but that is not only localized. So first question, localized or generalized, and this is localized maybe. So now what can be the local cause of this? Could it be congenital malformation and nothing to do with this? Or could it be related to some muscle disease as well? That is what we want to now discuss. Okay. What do you think?
What kind of protrusion of the chest do you know of, or have you seen or heard?
Rickets,
Okay, rickets.
cardiac disease, cardiac diseases, matlab hypertrophied heart.
Yeah, but cardiac disease would be maybe a precordial
Cordial
bulge, and it will not really be a protrusion to that effect. So protrusion suggests a little big popping out. So that is one you said is rickets. So specifically you want to use some word?
Pectus.
Quintus carinatum.
Pectus carinatum. So now that can that come at 5 years of age? This child is 9 years and started 4 years back. So can it come at 5 years of age? No, we have generally seen it as a earlier age group. Now, can you relate it to muscle disease in any way? Just thoughts.
Now, whenever you have some chest deformities, which other part of the body you look for flew to that chest? Chest, of course, you will examine. Which other part you would look at? And the spine.
Spine.
Okay. Now, if you have a spine also involved in this, imagine now, we are just discussing. See, one problem of a congenital malformation is as the bony growth occurs in the entire body, even a defective bone starts growing. And sometimes the parents, unless you ask, you never saw anything. No, it was there, but my doctor said it's all right, it's normal. And now it has been more prominent. So ask all those details. But let's believe that this has nothing to do since birth. Okay. In which case, how can a spine involvement? Okay. So my question is, can muscle involve the bony change anywhere?
Come on, what is the relationship of muscle disease to any spinal issues? So what happens in Duchenne's and all that to the spine? Is the spine good till the end?
Sometime in spine gibbous deformity or kyphosis develops.
Yeah, so gibbous is a local deformity, which is because of a problem with one or two vertebrae or something. But a kyphosis or a scoliosis can happen secondary to muscle disease and abnormal postures and all that. And that in turn can give rise to a chest deformity. So our possibilities are something which was less prominent earlier and has now become prominent, so they have seen it at 5 years, or something which is secondary effect of the muscle disease, right?
When spinal deformity comes in, the available space in the chest is possibly not the same. So you have to push some other part in order to accommodate all those parts. That's how the spine and the chest are related to a large extent, right? So that much we keep it open. What about the third point? Not gaining adequate weight. What's the problem? Have you seen a muscle disease not gaining weight? In fact, the muscle disease fellow cannot walk, cannot stand. He's mostly stationary. He's eating happily and gaining weight. So
Must be TB,
why is he losing weight?
national disease, no? TB.
There is a muscle atrophy which parents interpreted as not gaining weight or child losing weight.
So one suggestion is that the muscles are getting atrophied and parents are interpreting it that he is losing weight or not gaining weight. That is one. What else? Thoughts on not gaining weight. Suppose, so means again, same, you should start from broad. Every day in your practice, parents will come and say, my child is not gaining weight. What is the first thing you will do?
Nutritional or not
Even before that,
documented.
okay, even before that.
See,
Even before that.
weight is the outcome of imbalance between intake and output. If my intake is more, output is less, I gain more weight. Okay. Would you not like to know what is his intake like? Does he have a normal appetite and not gaining weight? Or he has a poor appetite and not gaining weight? Then you start discussing poor appetite only, forget the weight. Right? So again, negative question, what about your appetite? Okay. Now, can there be a disease where he's eating a lot and losing weight? Yes, which kind of disease?
Hyperthyroidism.
I thought so, because we never see one and we remember it very well. Something
So,
more common.
Yeah. So
You are right.
Next.
Yeah.
Huh?
Diabetes.
Diabetes.
Okay, fine. In children, diabetes is often not chronic, but acute. So they often come with diabetic ketoacidosis, not unlike adults who go on for a long time, polyuria, polyphagia, etc., losing weight. Yes, but you are right. So now what is it? Hyperthyroidism and diabetes is what we have read in the book. But what have we seen? Examiner wants to know in a postgraduate level, what have you seen more than what have you read? You might have seen something different than what you have read.
RTA.
RTA. But RTA will not eat well and then lose weight, no?
So malabsorption syndromes, which are non-inflammatory. They have a good appetite. Somebody who comes with chronic diarrhea for a long time, you say, oh, the malabsorption. First question, is he eating well and throwing out, or he has no eat? If he is not eating, it's an inflammatory malabsorption, celiac or whatever. And if he's eating well, then it's a non-inflammatory, right? So keep on that. Now, how do you go that? So possibly, this child may not have had a good appetite also. Why should he have no appetite? A muscle disease has no appetite. So what has muscle to do with appetite?
So any thoughts on how could muscle disease affect weight? Very good. So if there are any eating problems or feeding problems, so any swallowing difficulties and all that. So you think of all that, right?
See, now we are thinking this, so we should ask these negative questions. Okay, that have you had? After all, muscle, no? This is also muscle. So do you have any problem of incoordination or weakness or tone change of muscle? So how is your speech? Okay, muscle. So all those would be important to know. Okay. However, there could be many other reasons simply because he's not eating.
So again, just to stimulate thinking, not gaining weight, commonest cause is TB, no? So we should investigate him for TB, no? Yes or no? Everyone is making faces. What a stupid question I'm asking.
Fever, cough and cold.
So you are saying he doesn't have fever, cough and cold. So no TB. Okay. Any other reasons?
Yeah.
Not gaining weight can't be the only symptom for 4 years. And he should be developing something.
Very good. So he can't have not gaining weight as the only symptom for 4 years.
And
Okay.
I think whenever you have just somebody not gaining weight or not eating, your first question should be, is it progressively worsening or it is stable? If it's TB going on for some months, he's progressively worsening in terms of his activity, energy level, behavior level, sleep level, bowel serve, urine, so many things. But he said, no, everything is fine. Then you know it's a non-progressive disorder, and TB over time is progressive. Okay, those symptoms could be very minimal, but the progression is seen. Oh, lately he's not eating well, but lately he's also dull and he gets annoyed suddenly, he's irritable. So some changes which suggest that the disease is progressive. And that's why we want to know whether this muscle disease is static or progressive. And one reason to call it progressive is he's losing weight, he's losing appetite. Okay, so seems to be progressing. Besides, are his major symptoms also progressing? Of course. But even such small little thing tell you a progressive or otherwise. Because when we are going to talk about pathology and etiology, we are going to talk about static or progressive. Look at a developmental delay. First question, static or progressive? Cerebral palsy or a degenerative disorder, right? Same thing here in the muscle, right? Okay.
So just quickly, I asked you in practice every day somebody will come saying not gaining weight. What do? First thing is you look at the growth chart, which means you maintain a growth chart. Okay. And half the times what they think is not gaining weight is gaining weight nicely. So then your topic is over, no discussion. Anyway, now here also growth chart will help you, as sir said, whether it's progressive or not. So this growth chart becomes very important even in these chronic cases. Difficulty in holding objects in the hand tells you again about progression, because this is maybe since last 2 years and that was since 4 years. So the disease is
So
getting
progressing
progressive.
from below upwards. First walking, standing, and now. What is your comment? Like a GBS, progressing up. So does muscle disease does that? Progressing like this? Because all that is for 4 years now. Hand is only 2 years. So what's your comment on that? So generally the legs and the muscles of the lower limbs are often much more used than the hands. And as we go up, here we use very little. Okay, legs we use most. So the point is, therefore, the first symptoms are narrated to that. If you have a body ache, you don't complain to the doctor, my hands are also paining. He says, my whole body, but my legs are paining a lot because you're using legs more.
Your muscle bulk is more, and if you're talking of a muscle disease, it's going to show where there is maximum bulk. So that is why legs first, right? So there's no order. It is just a matter of observing the weakness.
So the next thing is it proximal or distal? Now we are on a muscle. So proximal.
She already said something, na? Which tells you proximal or distal. You said something, no?
Put the next slide. You have said many things in the next slide.
Unable to get up from sitting position and eventually supine position.
So difficulty in getting up suggests that this is a proximal worse than distal, right? Okay. Now, bony prominence we have discussed, no other swelling. Yeah, go on. Okay. Now, quickly you want to go through these negative histories, why you asked, and then we go to the possible pathology and etiology.
Sir, I have asked regarding no history of altered sensorium, convulsion or unilateral movement. I have to rule out any brain pathology or hemorrhage or any associated pathology. No history of
One
radiating
sec.
pain.
So see again, you have to tailor your no history to this patient. Na? This patient has since 4 years this problem. So whatever you are talking of, brain hemorrhage, etc., will it be over 4 years?
Yes, sir.
Right? So then you remove that. Then,
No history of radiating pain to rule out any nerve root pathology.
okay,
No history of diurnal variation, intermittent symptom with fasting or exercise,
okay,
like some pathology like periodic paralysis, वगैरह,
Okay.
that get aggravated with fasting or exercise. No history of muscle cramp or muscle pain, twitching. Twitching is more common with anterior horn cell pathology. No history of any deformity or spine or base of skull, like we have chest deformity over chest. So any associated other spinal deformity. Also like meningomyelocele and others. No history of any sensory loss or bladder bowel incontinence to rule out spinal pathology and sensory loss neuropathy. In neuropathy, we will have sensory loss. No history of fever spike. Actually, fever spike will not long for this polymyositis. In that, fever spikes are quite more common. No history of any chronic drug intake like steroids. Child is taking any steroid or statins. Then there is a possibility that child may have myopathy. No history of this weakness since birth. Or
yeah. So now this point again. So this way, if you put this history, it becomes very difficult. The examiner will wake up and will trouble you. You already given us history of motor delay, right? So in fact, this sentence should not come here like this at all. But at this point now tell us, how do you correlate that motor delay? So has this disease started at 5 years of age or has it started immediately after birth? What do you think?
Sir, to rule out that, I have asked next history. No history of this weakness since birth. If child has weakness at birth, then it may be presented like in the birth. Child has birth asphyxia or respiratory distress because of respiratory muscle weakness. But child has no such history.
Agreed. Birth asphyxia and respiratory distress will be prominent. But they will not come with these symptoms. As we said, they will not come with toe walking at 5 years of age, right? So which CP can come with toe walking at 5 years of age? Which CP can come with toe walking? So diplegic sometimes or sometimes the chorioathetoid kernicterus CP, right? Okay.
No history of constipation, mental retardation, protruding tongue or macroglossia. I wanted to rule out any endocrine pathology like hypothyroidism.
Correct. So now these are symptoms of, you're talking of congenital hypothyroidism, right? So again, congenital hypothyroidism at 9 years of age, when the child is now 9 years, these symptoms will be very, very prominent, and they will all automatically come as the chief complaints, right? Okay.
Whenever you are now considering a muscle, you need to look at 2-3 things: generalized muscle or a localized muscle. Like some of the myopathies are scapulohumeral, localized, facioscapular. So generalized or localized? Of course, this looks like generalized. That is number one. Second is there any hypertrophy in any muscles? Okay. What am I looking for? I'm looking for a difference between myopathy and dystrophy. Dystrophy is also myopathy. But I want to know whether pathologically is it myopathy or it is dystrophy. What is the difference between myopathy and a muscular dystrophy? Muscular dystrophy is also myopathy. What is the difference? Any difference between muscular dystrophy? In Duchenne, you call it muscular dystrophy. You don't call it myopathy. Difference.
There will be a pseudo hypertrophy.
So
All
why
right,
is
but-
it pseudo?
See, first thing is hypertrophy could be also due to nerve lesion, not only the muscle. So what is the classical difference between myopathy and muscular dystrophy?
Anyone?
In muscular dystrophy, like sir, you have told like Duchenne muscular dystrophy. In that, calf pseudohypertrophy is because muscle mass is replaced by fat globules. In myopathy, we don't have.
So first is the dystrophy is a progressive disorder. Myopathy is not progressive. Second is dystrophy is a genetically determined disorder. Myopathy may not be. So progressive, genetic. Okay. Third is there is a destruction of the muscle and infiltration by abnormal tissue. Myopathy is only atrophy. Okay. So that's why destruction and replacement by other tissues, that is hypertrophy. Now, these are the classical differences between myopathy and dystrophy. So the question is, are we going to call this dystrophy or myopathy? Okay. Moment we call dystrophy, we already said it's genetically determined and progressive. But when you call it a myopathy, myopathy may not be congenital, may be acquired, not only acquired due to neurological or a muscle disorder, but maybe endocrine, maybe steroid myopathy, whatever. So our etiologies go wider, but if we say muscular dystrophy, then we already said genetic. So we straight away go on to genetic issues, right?
So far there's no history of any hypertrophy of any muscle, no?
Yeah.
There's no history. Okay.
So we'll keep it open on that. But these are the questions in the history you should ask. Okay, because ultimately I want to know the difference between all this.
Sir, how would you react to the motor delay?
Actually, looks like that this has started motor delay pretty early. And therefore, I would still feel that this must have started very early. Because every important thing is getting delayed. Okay, sits with support 9 months, sits without support 15 months, even neck holding 5 months, little later. So the story has started almost since very early life, and that is very clear, and is obviously only motor. So when there is only a motor problem, it's only two things, musculoskeletal. So is it skeletal or muscle or musculoskeletal, right? So this is what rickets is musculoskeletal, whereas muscle is isolated muscle without the bone involvement. Okay, so we are dealing with muscle, not musculoskeletal. But when you had some abnormalities there, that's why I asked whether there are any other defects. If there are other defects, we would have called it musculoskeletal disorder, right?
Okay, so fine. So what is your summary now?
Sir, 9-year-old girl with gradually progressive weakness involving both lower limb more distal than proximal and in upper limb more proximal than distal, with involvement of gross motor delay and normal mental status in incompletely immunized child with normal birth and no significant history of past admission with intact sensation, to rule out muscular dystrophy, myopathy or neuropathy.
Do you think it is a Duchenne's most common muscular dystrophy? What's your question?
This is a girl.
It's a girl.
She's a girl.
So that's out of question. But can a girl also get Duchenne muscular dystrophy?
Exo Turner. External.
Turners. Okay,
Okay, yeah.
okay. Now, no, so you said in lower limb distal more than proximal. Why?
Because child in proximal, like child is not using her distal muscles. Child is not able to walk properly. She's
No, we said that child is toe walking because of a imbalance of muscles, right? But that doesn't mean that the child is not using distal muscles. So how will you judge whether proximal is worse or distal is worse?
like
Day-to-day activities can be a useful marker. Like
child has difficulty in getting up from sitting, and she when she presented to us that time, she used to take help of her upper limb to stand while from sitting position. But once she stands, she walks, but she has difficulty in walking. So I thought, okay, distance.
She walks without support.
She can walk without support.
So now my point is that if she can walk without support, but she can never get up without support, so which
She-
is worse?
So proximal muscles. are worse.
So proximal is much
I
affected.
think generally, if you go by the difference between muscle and nerve, the muscle yours generally starts proximally, the nerve distally. But when we are seeing a child after few years, all that difference goes away because everything is involved in either of the two. But the story starts with holding neck late, sitting late, standing late. Okay. And then last 2 years, even hand has come in. So the story is more proximal than distal, but of course now everything is involved, right?
And you also said neuropathy. So why neuropathy?
Actually, sir, I have interpreted distal muscle weakness more commonly, and in actually, I interpreted in lower limb like distal muscles are more affected than proximal, and usually neuropathic diseases have distal muscle prominent involvement.
Agreed. So your logic is right because you interpreted that way. Now tell me one important thing which is against neuropathy, and then
Child has intact sensation,
Very,
no tingling.
very.
feelings.
so in exam, if you give a differential upfront, you say, but the sensations are normal, so I am not able to fit that in. So that means then you are on good ground. Okay, go on. Examination findings.
On examination, child is supine, lying on bed with both lower limb extended and upper limb pronated and extended, alert with a conscious, cooperative, and oriented to time place person. Child is afebrile, pulse rate of 92 per minute, regular, rhythmic, equal in all four extremities, respiration of 24 per minute, thoraco-abdominal type, BP of 98/64 millimeter of mercury at 58th centile, saturation of 97% on room air, peripheral pulses well felt, central pulses well felt. Anthro-wise, a child has weight of 16.62 kg, which comes less than -3 standard deviation. Child has height of 125 centimeter, which is between -2 to -3 ST. Child has BMI of 10.63, which is less than -3 ST. Impression, child is severe thin. Also, child has mid upper arm circumference of L1 centimeter and head circumference of 51.2 centimeter.
We have gone wrong in our discussion. Your first line here tells me that there is a decerebrate posture. Okay. Upper limbs is pronated, extended, lower limb is extended, decerebrate, right up there. What's your comment on that? Typical decerebrate posture.
Actually, sir, this was supine.
Don't you agree? Decerebrate. Okay.
No. So what in that same line, what is there which rules out decerebrate?
She's conscious and
Conscious. Go on.
On head-to-toe examination, a child has oval elongated facies, skull head circumference of 51.2 centimeter.
Okay, you want to we have the child here, na, so we can try examining. Parent is not there. Carefully observe the gate also.
She can be stable? Yeah. Right. Shabash.
What did you observe in the gate? Toe walking. I should have asked, what did you observe with besides toe walking?
What all things do you observe in gate?
He is very cautious while taking each step.
She is cautious because obviously she is afraid that she shouldn't fall. What else did you observe? So sir also asked, what do you normally observe in a gate? Arm swing. So did her arm swing? No, her arms didn't swing much. What else? Normally, what do you observe? Normally, you observe the strike, the stance, and the swing, right?
And the distance between two steps. Okay, like this. Okay, Parkinson. So, distance between two.
What else did you observe? Something I want from one of you, I want, which means you are really learning the skills of observation.
There was no swaying or any, she was walking in a straight line.
Oh. Come on. Huh? Neck, she is not moving.
Stiff type of gait.
Huh?
Stiff gait. मतलब
Stiff. She's walking without support. One big thing. She's wearing a very loose t-shirt, but you should be able to make that out.
kyphosis.
Lordosis. She's walking like this. Now, why is she doing that? I heard something.
Hip joint, fixed flexion.
Hip joint is one of the reasons. So, why does anybody walk with lordosis? Compensation for?
See her chest protrusion.
It's not due to that. So, lordosis is to maintain the center of gravity. Otherwise, you will fall. Right? So, now we will discuss in detail some other time how hip and all that, Trendelenburg and all that. But basically, lordosis. So, that's why all Duchennes also walk like this. You know, all Duchennes have a lordosis.
Many times that may be the first symptom of a Duchenne. Okay, that is walking like this, whereas normally the child is almost bending to begin with and starts straightening thereafter, right?
Sure. Now, two people come and quickly do some observation and
Also, look,
examination.
I thought that there was also a little in-toeing. Okay.
Yeah, in-toeing, yes, of course.
So in-toeing is there. So we need to see what does it tell us. There is an imbalance between different muscles. Okay. Normally my foot should go like this. Now, if it is going like this, there is an in-toeing or out-toeing. And I think that also needs to be seen, right? Yes.
Chalo, one or two people to observe. Come. I can speak loudly.
Child is
Both of your legs, so that you can. Yeah. That's right.
she is sitting comfortably.
Hold closer.
Head to toe examination. Head looks normal in shape and size.
Faces are elongated and myopathic.
Faces are elongated.
Faces.
Now, whenever you start observation, what are the 2-3 things we do always 100 out of
Sick
100
looking or
times?
not.
So sick or not sick
not
first,
sick.
second,
Just comfortable.
Calm and
comfortable, fine, dash build and dash nourishment. So
Poorly-
average build, small build, well nourished, poorly nourished,
Poorly nourished
Poorly
and
built.
small built child.
fine. Go on.
She's having elongated faces with tented upper lips and
Ear, nose,
protruded chest.
ear and nose seems to be normal. Okay, there is a chest deformity.
So when you are only inspecting the whether there, okay, chest deformity, fine. When you're talking of the spine, you'll have to be careful ki whether she can straighten or is it kyphosis, all that you don't know. Okay, go on.
There's no icterus or pallor. Obvious clubbing, cyanosis.
No contractures.
We don't know.
Contractions.
We don't know whether there is a contracture at the ankle or no. Okay, what else? So in we've talked of a muscle disease. Now, in relation to a muscle disease, what else can you observe on inspection?
Small atrophied muscles.
So, and there's no hypertrophy.
Not
Okay, you can't see any visible hypertrophy. Muscle mass is good or bad?
bad muscle.
Looks poor. Muscle mass looks poor. Generalized poor or specifically
Generalized. Poor.
generalized poor. What else you want to see in muscle disease? You want to see any fibrillation,
Tongue.
fasciculation?
Tongue. Mouth open. मुंह खोलो.
With tongue protruding out or tongue inside?
Inside.
Tongue inside. Very good.
मुंह खोलो. There is no fibrillation.
You know, see it in the hand also.
By
How do you see fasciculation in the hand? So you just tell her to keep her hand like this and you will see a very tiny this thing like a tremor which is called polymini myoclonus. Okay. Fine.
Breathing fast.
not
Sorry.
apparently.
Breathing seems. Use of any accessory muscles.
Correct. So why do you want to see that?
Because there is a chest deformity, so compensation.
More importantly,
Muscle weakness.
yeah. So respiratory muscles, are they beginning to get involved? You want to look at that.
What is the power of the muscles? Can we just test, let her sit down, test her power of the muscles of the upper and lower limbs?
By check. Straight करो. पैर सीधा करो. ये पैर सीधा. It is more than 3/5.
Test it.
So
She is
first
able
we'll
to
check
do it
upper limb
against
power.
ability.
निशा असं करशील हात वर घेशील. This is against gravity 3/3.
असं कर.
ऊपर. और
See now proximal or distal one?
Proximal.
So one sec. So whenever you test power in the upper limbs, and you don't just say हाथ वर कर, because in the upper limb your flexion, extension, abduction, adduction planes are different. Always demonstrate. ये हाथ ऐसा करके दिखाओ. So that is your proper flexion, right? Go on quickly.
What about small muscles?
माझं बोट पकडशील एकदम जोरात
Good.
it's good. Grip is good.
Grip is good, okay. Then lower limbs.
Hip muscles first. पैर ऊपर कर. ये ऊपर कर. So hip muscle, hip flexor is more than 3/5,
Okay.
and extensor will check by walking.
Knee.
Knee extensors by check the more than 3/5.
Okay. Check
Ankle.
whether she has a contracture at the ankle.
This is her range of motion, and
So first tell me what is the difference between spasticity and contracture?
Stable on passive range of motion.
No, we do spasticity, we do clasp knife spasticity on active movement, no? So not necessarily passive.
Sorry.
So what is the difference? So
Contracture is to begin with the movement, and
Contracture is a muscular problem, whereas spasticity, it's because of the corticospinal tract.
okay, but clinically, what is the difference? So in contracture, you are not able to do the full range of movement at the joint. So what does contracture mean? There has been some fibrosis of the muscle or the tendon or whatever. So full range is not possible. In spasticity, there is resistance to movement. But if you overcome resistance, you should be able to do nearly full range of movement. It will depend on the degree of spasticity, right? So that's the first difference. And then within a contracture, you have a static and a dynamic contracture, right? So now what do you think this is? Is it spasticity or contracture?
it's contracture only because range of motion is decreased. It's not full.
Check for static or dynamic.
Actually, they are dynamic contraction because what I can move is more than 50% of
Not 50% doesn't decide dynamic. What decides dynamic? So what is R2, R1?
R1 is the initial passive movement that the patient can make without any force. And R2 is the external force that is applied by the examiner to fully flex or extend that across that joint.
So after the first point of resistance, if you can apply pressure and get some more movement, that is the dynamic part, right? So that can be helped by giving any kind of relaxants or whatever. That's a subsequent issue, right? Okay. So this is typically a child where all muscle power, she's an older child. So again, all of you go to the wards and examine her properly and try to look at all the power examination, because it will be easy. She's very cooperative and she's an older child, right? Anything else?
I think we have done all that. My question is that if she has a chronic progressive muscle disorder, then why is her power reasonably all right? We said the disease is from birth, right? And it's progressive. Okay. We said genetic, progressive. All right. We don't have any proof of genetic because there's nothing else here. So why is the power not so bad? Look at, she is able to move, she is able to walk also. Yes. So what kind of muscle disease is this? Is it progressive or not progressive? So progressive,
Based on the history, it seems to be progressive only.
progressive muscle disease, the child starts getting more and more wheelchair bound and gets worse in terms of movements. This child therefore may have some symptoms which appear later. Okay, the walking appeared first, the hand came much later, and we said why, but the muscles have been already there, and therefore this is more like a myopathy. It is not progressive. What is progressive? Progressive worsening of the muscle function. What is the progressive muscle function worsening? Muscle is not able to function. This muscle is able to function, but mostly the proximal, central muscles. Therefore, she has some difficulty. She needs help, but with help, she is able to do it. So finally, our impression is that this is non-progressive. Okay. Now that is the way I would go by, and therefore you would say this is a myopathy, not a dystrophy. Again, we said dystrophy is really a destruction of the muscle with infiltration, and there is none of that kind, right? Yeah. Reflexes.
So what is going wrong in the method that we are doing? She is doing something which is wrong. The child is doing something. Voluntarily. she is-
Extending knee
So how will that affect your reflex?
will not be able to interpret whether it is.
When she is voluntarily extending her knee, she is contracting her quadriceps. Na? So then where is the question? You can't tap on a contracted muscle. Correct? So you have to tell her, don't do anything, right? So she can sit a little back also so that she doesn't, and tell her, don't do anything. Your leg.
Diminished reflexes. It's not.
Did you get a reflex?
So I think your movement should be full movement of the wrist because you are tapping. So, okay.
Right. Try the other side. Yeah, so maybe you will have to make her lie down and take it indeed. Try biceps. So again, see, when we started just now, if you hold her arm in mid-air, Which muscles are getting contracted? Biceps. So then you can't get a reflex. So the arm has to rest somewhere. The forearm has to rest.
So on your own hand.
Okay, so best way is take it like this on your hand and
Yeah,
then do it.
Yeah.
You got, na? See, you saw the difference. So this is the technique. Always keep it on your arm so that you can relax the muscle.
Again, as there is no wasting anywhere, it tells you that this muscle has not been disused. It is using. That's another way you know that this is not a progressively worsening disorder, but it's almost static. And even having started near birth or early in infancy, even at this age, she's able to walk, but with some restriction. So there is no worsening really. And that's where we take away dystrophy and bring in myopathy. Moment you bring in myopathy, we already discussed that we want to know whether it's a congenital or acquired. And as it started very early, we are not considering acquired. Otherwise, you might look at thyroid, parathyroid, adrenal, steroid, all those things come into play when you're declaring myopathy. You might further look at electrolytes, hypokalemic, hyperkalemic, all those things start coming with acquired myopathy, right? Okay, good. Thank you. Yeah.
Thank you.
See, she needs a support while getting up. Yes. Okay. But once she's up, she can walk.
What is that chest thing is just
On head to toe examination, oval.
so anything that we have missed, you just give us a positive findings. You can do that?
Yes. One thing is, otherwise eyes say
Okay, go on. Read quickly.
hairs are normal in texture and color. Skull head circumference is 51.2 centimeter. A child has oval elongated faces.
This slide can you put off?
Eyes, no ptosis, squint, nystagmus or diplopia. Nose normal. Ear normal in size and shape. I had got that low set ear. Oral cavity keep mouth open while sleeping. Total teeth 20. Dental caries present. High arch palate present. Tonsillar hypertrophy present. Tongue is normal. No visible icterus pallor cyanosis clubbing. Lymphadenopathy. Neck is normal. Chest has visible bony protrusion, pectis carinatum in upper part of chest from second to fourth intercostal space. According to SMR, a child has a prepubertal staging. In upper limbs, arm, forearm, wrist and palmar muscle appear atrophic. Hypothenor atrophy present. No obvious any joint deformity of bilateral shoulder, elbow or wrist joint. In lower limb, all muscle group of both thigh, leg appears atrophic. No calf hypertrophy present. A major joints like hip, knee appears normal. There is dynamic ankle contracture bilaterally, more on the right side than the left side. Toe walking is present. High steppage gait is present. Actually, I had and a slight waddle I look, and then inward turning of sole while walking with bilateral pes cavus deformity and bilateral equinus deformity present. Spine is normal and cranium is normal. On systemic examination, cranial nerves are normal. On motor examination, like same only. On palpation, this atrophic, so nutrition is less. Power, muscle of facial expression within normal limit. On neck, a flexion 2/5 and extension 3/5, side to side movement 3/5. In shoulder joint, abduction of 2/5, adduction of 4/5, flexion of 3/5 and extension 3/5. In elbow joint, all is like flexion, extension, adduction, all are 3/5. abduction is 2/5. At wrist joint, palmar flexion bilaterally 4/5. Palmar and dorsiflexion, side to side movement 4/5. Hand grip 4/5. In lower.
One sec. Elbow joint abduction and adduction.
Actually, elbow joint.
What are the planes of movement of elbow joint? Huh? So don't always assume examiners are sleeping.
Okay. In the lower limb, sir, abduction was 2/5. Other examination was 3/5. In knee joint, also 3/5. At ankle joint, eversion was 3/5. Inversion, eversion was 2/5. Inversion 3/5. Dorsiflexion, plantar flexion 3/5. In reflexes, superficial like abdominal reflex present. Plantar was flexor. And deep reflexes, actually in knee reflex and ankle, I did not get. In the upper limb, also bicep, I had tried, but it was diminished reflex. So I had taken diminished to absent. In sensory system, superficial and deep sensation intact. Cortical sensation normal and 2-point discrimination present. Cerebellar sign में normal finger nose taste and no dysdiadochokinesia. Autonomous system within normal limit and no meningeal sign of irritation. Rest other systems are within normal limit. So my impression is 9-year-old girl with bilateral lower limb weakness, more proximal than distal, and also upper limb weakness, more proximal, with bony deformity over chest, with non-progressive weakness, with nutritionally severe thin and gross motor developmental delay, with normal mental status and intact sensation in completely immunized child, to rule out with normal birth history, to rule out myopathic disorder. This is the chest deformity that child has.
Okay, so it's like pectus carinatum only.
Yes, sir. This is the photo when child presented to us. Child has base cavus and equinus. Initially, child used to walk properly on toes, but now she flexes and distance is slightly reduced. This is X-ray on presentation. We had the lateral X-ray to see pectus carinatum involvement. On CBC, it was all lab investigation within normal limit. CBC with L1.3 HP, 38.2 hematocrit, L1000 total count.
So whatever is normal, you skip. If there's anything abnormal, tell us.
Sir, surprisingly, serum creatine kinase of we were suspecting initially with dystrophy, muscular dystrophy. So serum creatine kinase of 24.3, which was low, and then we had done thyroid profile, which is within normal limit. We had done 2D echo, which is normal. MRI was done, MRI NCO and whole spine screening, which is within normal limit. EMG NCV study done. Actually, in the morning, they had told provisionally that child has decrease in motor action potential, motor unit action potential, and early recruitment in right tibialis anterior, vastus medialis bicep, and flexor digitorum intermedialis muscle. But we don't have any specific diagnosis till now. Then child is nutritionally thin, so we had done other rehabilitation dietary reference, taking MNT, OTPT reference. Though child has provided with splint, and child won this, and now range of motion has increased, weight gain since admission, and we have the plan to do genetic workup. This is the splint we had provided, and now child is able to improve. That distance was more while walking. So toe walking has now gradually, child has decreased, and now using both.
Okay, good.
But I think in myopathy, you have a CPK low, that's right. In muscular dystrophy, CPK is low. High. Well, both are muscle disease. Dystrophy is a progressively worsening. His CPK should have gone down to 0. But their CPK is high. And here CPK is low. Come on. I know you know it. Just give a thought. When does the CPK increase? When there is a destruction of the muscle. You give an injection, CPK goes up. Okay. So dystrophy is a destroyed muscle, whereas myopathy is not destruction. So CPK is a destruction, and that's why the CPK goes up, right?
So sir asked, in dystrophy, can it ever be low? Muscular dystrophy, can it be low?
Put a hepatic parenchymal disease like an infective hepatitis, where the enzymes are sky high, can it get low? As the
Last stage. Very good.
end stage.
Yeah.
When there is no muscle to be destroyed, if there is no muscle to be destroyed, where is the CPK coming? But that's the end stage, right? Yeah.
Okay. So now we have our online faculty. Dr. Palni Raman has been answering most of the questions which you all are supposed to answer. But one important point he has made, that even intelligence, cognition known to be affected in Duchenne's, but not very great, a minimal affection, right? We were talking about cognition normal in this child. Now, there's one question by one doctor from Vadodara. What are the causes of non-inflammatory malabsorption? So I think what sir was meaning are the genetic causes where you have a specific enzyme deficiency which leads to malabsorption. And these are the children who are, because there no inflammation, they eat very well.
Even maldigestion ultimately is a malabsorption. And maldigestion can come from a pancreatic disorders, the biliary disorders. Okay. So enzyme deficiency, simply a lactase, for example, okay, is a non-inflammatory disorder. Whereas typical inflammatory disorders are what we talk about. Okay. So non-inflammatory are usually enzyme deficiencies.
Fine. So I think we stop this case here. And
But
now
it was a good presentation and a good discussion. All of you did that. Good.
very good. Now we have our online faculty, Dr. Anjali Gokarn. She'll be discussing constipation in the form of case scenarios, etc. So Anjali, have you joined?
Yes,
Okay, good.
I wanted to ask Payal whether her patient was constipated since she had a myopathy.
They don't know, they've not asked in.
Yeah.
She's saying no constipation.
Okay.
The way she said no, I thought she was hedging. So I said they don't.
Okay. Yeah. Good evening, respected Dr. Ambekar and all friends. And today I'm going to talk about constipation. If anyone has seen this movie, will know how obsessed Amitabh Bachchan was with his motions. And everywhere he went, he had to take his chair to poo. And this is how his whole family was affected because he was constipated. So what is constipation? Constipation is infrequent passage of stools which are hard, dry, or lumpy, and it's difficult to pass, or there is pain when passing, or a feeling that not all stool has passed. And how should a normal stool be? Like this, soft like a softie. But we have other kinds of stools to go by, and we have this Bristol stool chart. What is a Bristol stool chart? It's a diagnostic as well as a follow-up tool. And if you have type 1 or 2 kind of stools, sometimes it is important to ask parents what type of stool, because they may not know how to describe. And if you show them this visual aid, then they may be able to say. So if they have this type 1 or 2 stools, which are hard lumps or lumpy like a sausage, then they have constipation. And our softie is type 4. But type 3 to 5 are all normal stools, and type 6 and 7 are loose motions. But what is important to us is type 1 and 2 are constipated stools. Why do we need to know about constipation? Is constipation really a very important thing? Yes, it is. The literature says that 3% of visits to general pediatricians is for constipation, but I think it's more. 30% of visit to a pediatric gastroenterologist. So if anybody wants to be a gastroenterologist, they better know about constipation. But the incidence in medical colleges is very less. Just 1% of patients will be of constipation. Basically, constipation are functional or organic, as you know. And what are the features of functional constipation? Generally, it's in the later half of infancy. It's a well-growing child, playful, active. They have no difficulty in walking, meaning that they have no neurological dysfunction. The spine is normal. And if you examine the anal region, there is normal position, tone. But most important is they have this retention posturing of retaining stools. How does constipation begin? It always begins with improper supplementary food. We have lots of mothers who give watery food, they give them biscuits, and of course, they give them formula. And this is when functional constipation begins, when supplementary feeding is begun. This progresses to retention. That means a faulty diet gives a hard stool, which is difficult to pass, which causes pain, which may even cause a fissure. And this child then doesn't want to pass stool, withholds his stool. There is fecal impaction, there is lot of build-up, and finally it leads to chronic constipation. And what is retention behavior, which we said? I hope this is clear. If you see this girl, that's not a very good visual, but she's holding onto a chair and she's squeezing her gluteals, which are not visible, but she's squeezing her legs together. And this is what the other pictures also show. And these children strain very hard, and parents mistake this for constipation or difficulty in passing stool, whereas this child is straining not to pass a stool. How does one make a diagnosis of constipation? It's always with a thorough history and a physical examination. X-ray or barium studies are generally not needed to diagnose functional constipation. I will present some cases. This mother brought her firstborn 6 weeks old child for constipation. This child had passed meconium well on the first day. But when she presented, she said that he had not passed stool for 5 days. And since birth, he used to pass every 2 or 3 days. But this is the first time he's not passed for last 5 days. And everybody at home was worried. This child was otherwise feeding well, had no vomiting, had no abdominal distension. There were no signs of hypothyroidism on examination, and the TSH screening at birth was normal. This child has always been passing a soft and easy stool. So it's clear over here that this is a breastfed child, and this is a normal pattern of stooling in a breastfed child. 4 to 5 days, sometimes even up to 7 days would be normal. This is the second case. This 5-month-old child was breastfed till now, had normal stooling, had passed, there was no delayed passage of meconium. The mother had to join work from 6 months, and therefore she added formula by bottle and Nachni Sattva, which most of our mothers are very fond of giving. Nachni Sattva, let me tell you, they take out all the fiber and give only the sattva of, or the extract of Nachni or Ragi. This child had 2 episodes. This case happened recently, so it's very fresh in my mind. There were 2 episodes of severe stool retention, straining, and dry, and the diameter of the stool which this 5-month-old child passed was almost like an adult stool. Now, why I'm telling you that this was a large diameter stool is because this is to differentiate from another surgical condition which you may have to think of in an infant like this, like Hirschsprung, in which the stool would be like a ribbon. So all this child needed was counseling, change in diet. Now this child is better. The case 3 is a 10-month-old child, this mother was feeding diluted milk and rice kanji. This child had abdominal discomfort, poor appetite, and constipation, and that made things worse because mother kept saying that she doesn't eat anything and has only kanji. This child had failure to thrive, not really severe, but poor weight gain in the last 3 months. Now, here it's so obvious that there is inadequate substrate for this child. This child has, no fiber and no substrate, and this constipation has started in the last 3 to 4 months when child was fed supplementary feeding. Type 4, the case 4 is a 2.5-year-old child who was given only 1.5 liter of milk daily by bottle. That's because the parents went to work and the grandparents thought that milk will make this child very healthy. And this child had abdominal pain, had withholding behavior. He would go into a corner, straighten his leg and strain. And his grandparents thought that he was straining to pass a stool and didn't know that he was actually straining to withhold it, and was in a nappy all day. So again, here it is so obvious that this 2.5-year-old is given very low fiber diet and the abdominal pain, and this child, of course, will have a poor appetite because he has constipation, as well as if anyone drinks 1.5 liter of milk, will not want to eat anything else. Case 5, this 4-year-old child had a previous history of constipation, was taking treatment, was on maintenance lactulose. Both parents were working. This child was in a nappy at daycare all day. Now, what is important is this child has taken treatment earlier, but has taken only part treatment. The parents have no time to give this child to train him for passing a stool, because management of constipation just does not mean giving a stool softener or changing the diet. It also means toilet training. So here what was lacking was toilet training, but of course we have to add a second stool softener or a laxative over here. Case 6, this girl was 10 years old and was brought with pyelonephritis to us for the first time, was hospitalized, had severe illness, and had to be given IV antibiotics for 10 days. And even after that, she developed, allergy, and it was a very long course. She took almost a month to recover. Constipation history since many years. She would take intermittent treatment, feel good, and then, give it up. This girl had significant academic and behavioral issues. There was family dysfunction. Why I have said this is because this is multifactorial. The cause of so it's not that the academic or behavioral issues are caused by the constipation. It's these issues that has, added to constipation. Very little attention was paid to it because a lot of attention was paid to the academics and very little to constipation. And chronic constipation can lead to pelvic floor dyssynergia, can lead to voiding difficulties. The fecolith can press on the bladder neck and cause retention, and ultimately this child develop pyelonephritis. So this is a grave side effect of having chronic constipation. And this 8-year-old boy was brought with what mother said was loose motions and was actually encopresis. This child was always soiling his pants and underwear. He was shy and withdrawn. He never sat down on the chair to be examined. He wouldn't allow me to do any kind of examination. He was afraid to go to school because he was always soiling his pants and nobody wanted to be around him. He didn't go to play as he was always smelling of poo. And the parents didn't think that this was because of constipation. They thought this was loose motions, and anyone who tried to prescribe any kind of laxatives to him, they didn't get any response, or the parents didn't think that it was important, and there was poor follow-up. All these cases are actual cases we have seen. So constipation is not so benign. Constipation, the child suffers, there's local pain, there's fissure, there's bleeding, there's poor appetite and chronic and recurrent abdominal pain. The family is preoccupied, is distressed. Long-term effects of loss of rectal tone and chronic constipation, like in our 10-year-old child. There is perennial muscle weakness, dyssynergia, which can lead to urinary symptoms, frequency, enuresis, urinary tract infection like pyelonephritis in our child. There can be encopresis, soiling, and a severe blow to anyone's self-esteem and severe social avoidance behavior. There can be hernia and prolapse of piles because of straining when passing stools. So what is the basis of management? It's a 5-prong. Parental counseling is very important to tell them the importance of constipation and that it is a long-term treatment. That diet and fiber are equally important. That there should be toilet training. That the child should be kept in the toilet within half an hour of having a major meal. And one person should be dedicated to do this at all times. This child should engage in a lot of physical activities. And of course, the last is medical therapy. So no one thing is going to work and all 5 have to be done. Of course, management would include lots of fruits and vegetables. It would include lots of fluids. The Indian way of squatting, I think, is the best way because this is the right position in which the rectum is, in a very straight line to pass stools. But of course, you can modify it any way you like. And if you're using a Western toilet, then the children should be encouraged to have a footstool, which gives at least 30 to 35 degrees, flexion at the hip, which will bring the rectum into, and lean a little forward, which will bring the rectum in a straight line. All children should be encouraged to sit on a child potty because that is squatting position. And if a child is afraid to go to a Western toilet, then having a child seat also helps because that may be one of the reasons of withholding behavior or retentive behavior. Child to engage in all kinds of sporting activity. This has become so important to say again and again with all kinds of mobile addiction and mobile activities and very little of outdoor activity. But outdoor activity also helps in constipation, so physical activity. And of course, we come to medical management. Medical management is divided into 2 parts, that is disimpaction and maintenance therapy. Disimpaction is for chronic constipation when there is a pileup of hard stools in the rectum and colon. And maintenance therapy is after the initial disimpaction and clearance of the colon and rectum. What is disimpaction? It is done either in the hospital setup or in the home setup. If a child has severe abdominal pain, very often in the hospital, we do give an enema to relieve that severe pileup. And home management is with polyethylene glycol, which has to be given over a period of 6 days. Disimpaction is done for chronic obstruction, and polyethylene glycol is preferred. It is given in a twice daily dose. It's given for a short period for 5 to 6 days. And at times, enemas in hospitals are also required. After good disimpaction, the maintenance therapy is required. And generally for this, lactulose or lactilol is preferred. And treatment is continued for anywhere between 2 to 6 months. It's not like a 2 weeks course, but anywhere between 2 to 6 months. And treatment has to be tapered off after 6 months once the child has achieved complete clearance as well as is toilet trained. If there is no adequate response after 2 weeks of therapy, then a second agent may be considered. At times, while the child is on treatment, may have, intermittent constipation while being relieved initially, and we can add either picosulfate or bisacodyl for this. And this is only when child has done well initially and then has a brief period of retention. It's given only for 2 to 3 days. There are many brands and many kinds of osmotic laxatives as well as other stimulant laxatives. We need to know very few and we have to stick to them. I use just 2 or 3 in my regular practice, and it's important to know the dose of what you have been using. But of course, look out for red flags. It's not that everything is functional constipation. Look out for red flags for organic causes. And what are they? If the child is not gaining good weight or height, if milestones are affected, of course, when milestones, one would think of hypothyroidism, if there is vomiting or even bilious vomiting, abdominal distension, if you find an abnormal anal position or tone, if you find any spinal abnormality or any lower limb gait or limb abnormality. That means if any of those red flags are present, there is secondary constipation, and I'll be presenting few cases of that. This is, of course, hypothyroidism. Any child who doesn't pass stool in the first 48 hours has these signs or has an abnormal TSH on screening, one must think of hypothyroidism. Very rarely, or rather never, would hypothyroidism present with solitary constipation. This child, very interesting. This child was transferred to the NICU for transient tachypnea, but child was also vomiting and had abdominal distension. This abdominal distension would get relieved. This child did not pass stools, had abdominal distension, vomiting along with tachypnea. And like is our practice, we gave a glycerin enema and that abdomen became very, very soft. But again, after a period of time, the abdomen would distend, child would not pass stools and would have occasional vomiting, and we had to give an enema again. This X-ray was done on day 3 or 4, and you can see that this colon is already dilated. Now, this became very distressing that this child would need an enema every time the abdomen distended. And we thought of transferring this child because this looked like a surgical case. And sure enough, it turned out to be Hirschsprung's disease. So any child who does not pass stools in the first 2 days, first 48 hours, it's a red flag sign for any kind of surgical or other cause. So this turned out to be Hirschsprung disease and had to go for a colostomy. I have taken permission of the mother of this child to show her picture. This girl died 25 years ago. This child was brought to her NICU again because she did not pass stool. She had abdominal distension. And she had this X-ray when she came, and this was ileal obstruction. But what is so any child who has an ileal obstruction would pass meconium in the first 48 hours because after the stenosis is formed, after the stool is already there in the distal part to the stenosis. But in this child, the surgeon who operated told us that for almost a week, the secretion, the stool matter was so thick and viscid that they had to give various kind of enemas to make the child pass stool. And this was a classical case of cystic fibrosis. This child grew up to have very frequent respiratory infections, died at the age of 4.5 years, 25 years ago, of staphylococcal pneumonia. It's not known, the children, when they grow up, they are not known to have constipation as a presenting feature, but they don't pass stool in the first 48 hours. So if a child has not passed stools in the first 48 hours, please think of hypothyroidism, think of Hirschsprung's disease, and think of cystic fibrosis. This child was 4 months old. This picture I have got from a surgeon. And this child had, again, lots of abdominal distension, occasional bilious vomiting, was referred by a pediatrician to him. And he did a barium enema. And you can see that there is that aganglionic segment near the rectum, and there is ballooning of the rectum and the sigmoid colon. So this was Hirschsprung's disease. And this is also Hirschsprung's disease, which was diagnosed very late because for various reasons, child came when he was 3 years old. You can see a long segment distal to the sigmoid colon. This child had a long segment which was aganglionic and also was Hirschsprung disease. So please remember, if you're finding it difficult to treat a child and this child passes ribbon-like stools, not so in a child who has functional constipation, the quality of stool is different from that of a Hirschsprung's disease. A Hirschsprung's disease would have ribbon-like stools, whereas a child with functional constipation will have large diameter stool. Sometimes they say that the large stool blocks the western toilet. So please remember this difference. If they don't complain of large diameter stool, then think of Hirschsprung's disease. But of course, if you find it difficult to treat any patient, refer to a gastroenterologist or to a surgeon. This child, same in lateral. This child was referred to my surgeon friend as, again, a difficult to treat constipation. And you can see lower down, there is lot of fecal loading and dilatation of the colon. Of course, this child also has a right-sided congenital diaphragmatic hernia, but that's not the discussion today. This child had anal stenosis. So, do we have to do a per rectal examination for every child who comes to us? Not really required. But if you find that this child does have some difficulty in passing stool, I had an embarrassing situation once. I had been treating a patient for constipation, and once this child had a very severe abdominal pain and a lot of stool retention, and I took this child to give her an enema. And when I opened the anal canal, I saw that there was stenosis. So when will you do a per rectal examination? Ideally, you could do it every time, but if you find a child difficult to treat, then do look for anal stenosis. This child was referred to the surgeon by some other pediatrician for anal stenosis, and this is the X-ray of this child. So anal abnormalities can cause, of course, if on examination you find a sacral dimple or a hairy nevus or any other abnormality over the lower spine or the upper spine, do think of spinal dysraphism and investigate this child. This child may have presented with. So in a general examination for a child, for in fact any child, please do look at the spine. But especially in a child with constipation, look at the sacrum and also do the lower limb reflexes to see if there could have been some spinal dysraphism. So we have seen secondary constipation, which was because of hormone, that is hypothyroidism, surgical cases. Systemic illness, we saw cystic fibrosis, but celiac disease is another disease, and irritable bowel syndrome and other inflammatory bowel diseases can also cause constipation. Metabolic like hypercalcemia, hypokalemia can cause constipation. Spinal cord and neurological problems are known to cause constipation. And of course, like I said, anal malformations, anal stenosis can also cause constipation. If you suspect a secondary cause, don't go for treating it yourself. Refer to an appropriate specialist, either a gastroenterologist or a pediatric surgeon. In summary, constipation causes pain, distress. Functional constipation is a clinical diagnosis. Recognize and treat it well. Chronic constipation can lead to other morbidity, like I said, encopresis and pyelonephritis. It's a multi-pronged approach, not just one thing, but counseling, diet, toilet training, and medications. Recognize red flag signs and refer early. I have taken references from consensus practice guidelines of Indian Society of Pediatric Gastroenterology. This is in Indian Pediatrics. 2018. It's a very elegant article, and I would urge everyone to read that. I've also taken some references from IAP treatment guidelines on constipation. And of course, I have seen 2 videos of Dr. Amdekar on YouTube on constipation, a gut in slow motion, and also there is a 3M site where Dr. Amdekar has given an elegant lecture. And there are some lovely charts in Nelson's textbook of pediatrics. But I will leave you with this image. This child was 4 years old and was referred so late. This child had Hirschsprung's disease. And the pediatric surgeon who saw this in KEM said that I could just see the abdomen when the child walked in and nothing else. That's all for me. Thank you.
Thank you, Anjali. Any questions from anybody? Okay.
Dr.
you.
Amdekar can give us some tips. He is.
I think you have done a wonderful job. I'm very proud of you.
Thank you
very
so much, sir.
We are late. Can I take 5 minutes? Anjali, you did a great job.
Thank you so much.
I'm Hemant Joshi. I'm going to entertain you. I'm going to sing a baby song. Baby says, stomach paining, stomach paining. Yeah. Huh? No, Karuna. It's science in a happy way. Baby says, stomach paining, stomach paining, stomach paining just now. Call the doctor, call the doctor, call the doctor just now. Watery feeds, watery feeds, watery feeds just now. Constipation, constipation, constipation just now. Stop milk, stop watery feeds, give home feeds just now. Thank you, doctor, thank you, doctor, thank you, doctor, just now. If you understand this baby song, we have treated constipation. Functional constipation is a wrong name. Starvation constipation is the right name. Ignorant parents is the right name. What is India's national illness? Constipation. Largest number of adults have constipation. If a baby is born in India, baby has to have constipation. I learned this in practice. Only Adivasi children do not have it. It is a secular illness. Hindu, Muslim, Sikh, Isai, everybody's baby born in India has to have it because we give them milk and watery feeds. Pediatricians must change this. Indians are ignorant of the fact that babies need good home solid food. Baby's food should be taken in a spoon. You bend the spoon, it should not fall down. If it falls down, he's getting more water, he'll do more susu, constipation. The feces come out, they cause anal fissure. So if you put Prelox cream, Emla Plus or Emla on the anus, the pain goes and baby passes motions in the earlier if the baby comes early. This is the treatment. Then it is bread butter of pediatrician. If people become wise, we will be out of business. 1 minute more and I'll tell you. We do not know how to eat right. Half of what we eat must be vegetable. Or if we eat right, our babies will eat right. We must eat like this and we must feed our babies like this from 6 months of age. Thank you.
Thank you, everyone. Thank you, our online viewers. Thank you, online faculty. Thank you, Anjali, for that crisp revision of constipation. We meet once again on next Thursday at 6 p.m. Thank you.
Thank you.
Maple syrup. I brought something for you. Yeah.